As you may recall, at the end of our last get-together, we were dealing with the subject of edema, and we outlined the pathogenesis, the various pathways by which edema fluid comes to accumulate in various tissues. And I think I made the point, I hope I made the point, that edema in and of itself doesn't generally damage tissues. In other words, if you've got a pair of swollen ankles, it's cosmetically unpleasant, but in and of itself it's not important, except it points to something wrong. On the other hand, edema, if it's severe and persistent over long periods of time, can produce permanent changes. I showed you that god-awful picture of elephantiasis as an example. And just as the bell went off, we were making a final point that in a few locations in the body, just on a purely mechanical basis, edema can be life-threatening or even fatal. And I illustrated pulmonary edema as an example of that, and I think that was pretty obvious. Just begin today with a couple of loose ends before we get on, and point out that another place where we occasionally see edema that's very significant, and I've seen people on the autopsy table because of this, is laryngeal edema. This is a posterior view of the larynx. Things have been opened here, and you can see that the epiglottis is quite swollen and red, and all of the laryngeal tissues are edematous, and this can go down to the point where it closes the glottis. You can see this in certain infections. I don't want to say it's common, but I have seen people killed by infections here producing laryngeal edema, and it's a part of systemic anaphylaxis, anaphylactic shock, a super-duper allergic reaction, which you may or may not have heard about yet, but one of the things that can happen in addition to a lot of pulmonary things is you can get a very life-threatening or lethal laryngeal edema. Then there's one final place which will become obvious as soon as I mention that, and that is the brain. Now the brain is locked inside a bony box, and there's very little spare room in there, which means that if the brain gets edematous, it's going to swell and fill the space within the head. The swollen brain is going to get pressed against the inside of the skull, and if the edema is severe enough, it will compromise venous return. It begins to press on the veins that have to carry blood out of the brain, and you get into a vicious circle where pretty soon blood flow stops. And when that happens, neurons die, and when the vital centers are affected, respiration stops, and it is lethal. And we see this, unfortunately, a lot of the time, and trauma is one of the best reasons, or worst reasons for this. You can imagine that when a car is speeding along and hits something, and you have particularly if you have an unrestrained passenger and the head hits something, the brain inside is going to get rocked around. You see some hemorrhages here. This is an I-94 brain. And what you can see here, if I point it out, it isn't immediately obvious, is that the convolutions are flattened, the gyri, that is, instead of being kind of nice convex things, are flattened, and the sulci in between are narrowed to just slits. That's a very, very edematous brain. And what happens is, as I say, it swells up, and it pushes the hind part of the brain down through the foramen magnum and screws up the circulation, and it is frequently lethal. And the brain can't tolerate too much edema. Normal brain weighs about 1,400 grams. You don't have to remember that, but I've seen very few brains over 1,600 grams. I mean, that's just a couple hundred grams of extra fluid in there will do it. So edema can be, in and of itself, lethal. Well, that was just the tag end of last session. What I want to talk about during this entire period now is another very important and very familiar circulatory abnormality, namely hemorrhage. You're all familiar with it. You've all hemorrhaged. It's no mystery. And I would just emphasize that hemorrhage is escape of blood, any escape of blood from the confines of the cardiovascular system. It doesn't matter where it goes. If it goes onto the floor or into that gauze that you're blotting the wound with, that's hemorrhage. But the very important thing to remember is there's equally important hemorrhage into the tissues of the body. Certainly the soft tissues of the body can take up an awful lot of hemorrhage, and certainly the body cavities, which the pleural cavity or peritoneal cavity can contain a fair fraction of the total blood volume. So hemorrhage can be totally internal and be just as significant. Now, there are different clinical patterns of hemorrhage, as you might imagine, and these are given special names, and some of them you know, but I'll flash these on and go through them because this has got to be part of your storehouse of words, familiar words. The smallest hemorrhages, little pinpoint jobbies, maybe a millimeter or two, or even a little bit less, but just a pinpoint of hemorrhage. We call petechiae, that's the plural, because they usually occur in crops, but the singular is petechia. But we always talk about petechiae. So there's little pinpoints of hemorrhage. Then there are blotches of hemorrhage. You've all been bruised is a good example of an ecchymosis, plural ecchymoses. And then closely related, not much different, is a hematoma. We usually use that word when the blood has actually formed an oma, a mass. It's a mass of blood, a lump of blood. That's hematoma in the tissues. And then you get into bleeding into various places, and you just need a little bit of Latin and Greek. Hemothorax is blood in the pleural cavity. Hemarthrosis is blood in the joint. You've got hemopericardium, hemoperitoneum, hematosalpinx, the fallopian tube, and so forth. Then there's a word that is egregiously misdefined in your text, and that is purpura. And purpura refers to a general condition, not a specific little lesion. You don't say that lesion is a purpura. A patient who has widespread cutaneous and maybe mucosal, but primarily cutaneous hemorrhages, just as blotches of hemorrhage everywhere, we say that patient has purpura. Or we talk about a purpuric sort of appearance, meaning very, very generalized condition. And I'll show you these things. I think you're familiar with many of them, but there are lesions we call petechiae. Some of them are getting quite big already, but even these little tiny pinpoints, those are petechiae. There's a good ecchymosis. There's one there, one there, one there. Just, you can imagine just a splotch of blood percolating through the tissues, producing that ecchymosis. There's a wonderful hematoma. That's a lulu, isn't it? It really is a mass of blood. And there's a patient who is suffering from what we would say purpura. He has some condition which has produced purpura there. Just ecchymoses and petechiae, hemorrhages pretty much diffusely over the surface of his body. Well, as you might predict, if you think in evolutionary terms, you might predict, since hemorrhage is such a potential threat to the organism, I mean, you can spill your blood out on the floor and die, there would have evolved, and there have evolved, some very important hemostatic defenses. In other words, defenses against hemorrhage. And there are three major players in this defensive system. It's an overlapping, sort of redundant and interlocking system, but there are three players that we have to keep track of. This makes perfect sense. It's the blood vessels, the blood platelets, which I guess you've discussed in histology, haven't you? And the coagulation system of the blood. And I'm going to sort of take them one by one and just comment on them, starting with the blood vessels. You know that the entire cardiovascular system is lined with a continuous layer, which you've learned as endothelium. And the endothelium is very, very important in maintaining the fluidity of the blood. I mean, we want the blood to be fluid, generally speaking. And this endothelium is a very slick, smooth, non-sticky surface. It's a slick surface. Things don't hang on to it ordinarily. That's sort of a physical characteristic. The endothelium also, as you know from thinking about it and studying in histology, it separates the circulating blood from the constituents of the vessel wall. And this is very important because when flowing blood is exposed to stuff in the wall, I won't get into the chemical details, but when it's exposed to stuff in the wall beneath the endothelium, it clots. So there's a very important physical barrier function there. But what I'd like to emphasize, and you can read a little bit about this, but I don't want you to get lost in the detail. The endothelium is alive. It functions, it metabolizes, and it produces goodies of various sorts. And that's very important. Now, I say right at this point, learning what each of these goodies isn't important. Ramsberg will assault you with it a little bit next week, but I think the big picture is more important that normal endothelium, intact normal endothelium that hasn't been brutalized in some way, has anti-clotting properties. Very active anti-clotting properties, whereas injured endothelium becomes actively pro-thrombotic, in other words, pro-clotting. And it acts in concert with platelets and with the coagulation cascade to plug the hole. All right. Another point to make about properties of vessels, getting away from the endothelium for just a moment, is that when a hole is poked in a vessel or torn in a vessel or whatnot, there is at least a transient vasoconstriction, at least of those vessels that have smooth muscle in the wall. And you can imagine that clamping down, that vasoconstriction is somewhat of a temporary measure. It's at least to slow down the hemorrhage a bit. And this is partly neurogenic, and it's partly mediated by endothelin, which is a product of the endothelium. So here's the endothelium helping out again. But very importantly, when we talk about damage to vessels and hemorrhage beginning, is that the blood, if you injure a vessel, the blood is brought in contact with stuff in the vessel wall, and that produces a whole lot of changes, activating blood platelets and the coagulation cascade. So I want to turn to those next in turn. We've said, a quick survey of what blood vessels do. What about the platelets? Well, you know about platelets. You've seen them in histology. You give an idea of that the average erythrocyte is about, 7.5 microns in diameter. So these are little squirts. You see it in a different stain here, but you compare them to erythrocytes, you can see that they're little tiny, basically fragments of cytoplasm. And they circulate in large numbers. The normal numbers somewhere, it's a wide variation, but most of us in the room here have something between 150,000 and 300,000 platelets per cubic millimeter of blood in health. These platelets in turn, and again, this is review for you, I hope, are made by megakaryocytes in the bone marrow. This is a shot of bone marrow, and you have cells here producing leukocytes and erythrocytes, and it's these big jobbies, these giant cells, there and there, one down there. Those are the megakaryocytes, and basically, the business of megakaryocytes is to nuzzle up to the edge of a sinusoid and shed cytoplasm into the circulation. And the cytoplasm comes off sort of in ribbons, and these are the blood platelets. And I saw a figure last night. I'd never heard it before, and I can't vouch for it, but somebody has claimed that a megakaryocyte produces somewhere between 1,000 and 4,000 platelets, if you like that. And this is a continually renewing thing. The platelets don't last all that long in the circulation, a matter of about 10 days, I think it is, and they're renewed from megakaryocytic activity in the marrow. In one sense, in health, when someone isn't knocking a hole in a vessel, the platelets mind their own business. They circulate around and they're happy fellows. But there is something more subtle going on there, and it turns out that platelets have you might call it a trophic effect on the endothelium. In other words, platelets are essential to endothelial health. And it turns out if the platelet count goes from, say, a couple 100,000 down to 20,000 or 10,000, that's usually the figure quoted, between 10 and 20,000, the adherens junctions between adjacent endothelial cells, there's tight junctions there, they begin to unzip. And the result is red cells escape from these gaps that are produced by the unzipping. It's primarily in postcapillary venules, but then you get petechiae. So if people lose their platelets down to a level of 10 or 20,000, they're going to have showers of petechiae from just the interruption of the integrity of the endothelial lining. All right, assuming you got a normal batch of platelets and you're minding your own business and they're circulating around. Question?
Yeah. So if when looking at adherence junction, wouldn't it be a more generalized condition of petechia? Would you be getting a purpura if you're having this general?
Well, they tend to be very small. In other words, just from dropping the platelets like that, non-traumatic hemorrhage, I'm talking about, let's say you had skin that was perfectly shielded from getting knocked on, they'll be petechial hemorrhages. They don't
have purpura have some sort of trauma?
No, you just have to have other things happening. It's generally petechial if it's just a matter of the platelets dropping. I suppose in the extreme it could extend, but you think more of a petechial rash. You'll see patients who show up with just showers of petechiae, particularly in the lower extremities, and you discover their platelets are way down there. All right, but let's say you've got the normal complement of platelets, and something knocks a hole in a vessel wall. I'm using that metaphorically. It's either physical trauma or it can be disease or whatever, but there's basically a defect that appears in the endothelium. There's a hole in the endothelium, and the flowing blood with its platelets flow by this raw spot in the vessel. One of the things that happens, and again, I'm not big on your learning the mediation of all of this, but what happens is the platelets, the passing platelets, very rapidly adhere to that raw spot. They won't adhere to normal endothelium, but because any damage to the endothelium, the platelets begin to adhere. They change their shape. They're ordinarily rather smooth. They become kind of stellate and spiky, and they adhere to each other, which means that you start out with a few platelets adhering, more platelets pass by in the flowing blood, they adhere, more come and they adhere, and pretty soon you got a pretty good lump of platelets in this raw spot. And they can, just a little platelet clump can actually occlude a small hole. But one of the things, very important things that happens is that these platelets, as they're coming together, and I'm sort of oversimplifying here, they release a variety of substances from granules in their cytoplasm. And these substances do a number of things. They potentiate further platelet aggregation, further platelet accumulation, and very importantly, they potentiate the clotting of the blood, that is triggering the coagulation cascade. So very quickly after injury, these platelets form what's sometimes referred to as a primary hemostatic plug. It's a temporary thing. Got a hole, a little pinhole in a vessel, platelets, plug it up, that's fine. But with the addition of the coagulation system, when that kicks in, then you've got what becomes a permanent hemostatic plug. Sort of a 1-2 punch, platelets then coag. So I want to pass on very quickly to the coagulation cascade. Now, I don't know if you've had your nose rubbed in this yet, but it's a very complex business, which I want to just stress the big picture, not the details. You can read in the book to your heart's content, but just I want you to have the big picture. The idea here is that the coagulation cascade is and there's a diagram in your books, you've got this in your notes, but it's a cascade starting with factor 13 and working all the way down. And there are, each of these factors exists in an inactive form, and something triggers the activation of that factor, and that triggers another factor, and so as a downward cascade, which I'm not terribly concerned about now, except to point out that the final result of all of this is the precipitation of fibrin. Now, you know that fibrin comes from fibrinogen. You've learned that. You learned about fibrin in exudates. Fibrinogen escapes, then it becomes fibrin. In terms of blood clotting, the backbone of a blood clot is fibrin. You've all seen a blood clot. You cut yourself, the blood clots. It's fibrin. Draw blood off into a tube and allow it to clot. The backbone of that clot is fibrin. So fibrinogen goes first to this is a detail, goes to a soluble form and then becomes an insoluble fibrin. This occurs under the influence of thrombin. In other words, when thrombin acts on fibrinogen, you end up basically with a fibrin clot. Now, thrombin doesn't circulate in an active form. That would be a very bad thing. You'd clot as you were sitting here. So there is prothrombin that has to be converted to thrombin. And this is done through products of this whole cascade here. But the important last step I want you to know for sure is that thrombin catalyzes this reaction of fibrinogen going to fibrin. And I saw a statement, again, I can't vouch for these, but they're interesting to contemplate, that 1 teaspoon of blood has enough potential thrombin activity. If it were all activated, 1 teaspoon of blood could clot 2 to 3 liters of blood within 15 seconds. Pretty amazing mechanism. But what it also says, I mean, because you're sitting there and none of you look like you're clotting, is that there's some very important checks and balances in this system. There are enzymes that inhibit one or another of these elements of the cascade and that really control the tendency to coagulate inappropriately. And there is even a system for dissolving the fibrin clot. And this is one that you should know about. And basically, there's a substance called plasminogen, which we all have circulating in our plasma. And that can be activated by plasminogen activator, in this case, tissue plasminogen activator. Plasminogen can be activated, becomes plasmin, which is a proteolytic enzyme. It's a fibrinolytic enzyme. So when plasminogen converts to plasmin, it can dissolve, very potently dissolve fibrin. And there's a balance between thrombus formation, clot formation, and fibrinolysis. And I suspect it goes on. You've had a 4-hour morning sitting on your back ends, and you probably got little clots in the venules of your fanny, and they get dissolved away. There's a nice balance in life, and you live happily ever after. But it's an important part of the whole mechanism.
Doctor,
yeah.
Is the plasmin specific solely for fibrin?
I don't know enough about the chemistry. My guess would be that it's a general fibrinolytic, a proteolytic sort of thing with a certain focus. And the way it's released, these are, I'm giving you broad brushstrokes. These things tend to be localized in certain ways because they activated only under just the right local circumstances and so forth. Now, with all of this, with the properties of the blood vessels and properties of platelets and the properties of the coag system, despite all of those things, people bleed. They get into trouble for bleeding. And the question is, why is there hemorrhage in the world? The first answer to that, the biggest answer is, and the biggest cause of hemorrhage is loss of integrity of the blood vessels. You smash a blood vessel, tear it apart, drill a hole in it, you physically injure it in some way, there's going to be hemorrhage. So trauma is the #1 cause, probably, of hemorrhage. And you've all had traumatic hemorrhages in your day, as you well know. vessels can have their integrity destroyed by disease as well. There can be congenital weaknesses in vessel walls that give way and produce hemorrhage. There are any number of acquired sorts of conditions, inflammatory conditions. Hypertension can injure vessel walls and lead to hemorrhage, as it does in the brain frequently. Atherosclerosis can weaken the wall of a vessel enough that it bulges, produces what we call an atherosclerotic aneurysm that can rupture and produce hemorrhage. So highest on the list is loss of vascular integrity. A second category of causes of hemorrhage is deficiency in the platelets. And this can occur in a number of ways. Platelets come from megakaryocytes. So if you have a process that destroys the megakaryocytes in the marrow, the platelet supply is going to dwindle very, very quickly. And a deficiency of platelets, you may know the word, is thrombocytopenia. Thrombocytopenia. Thrombocyte being a platelet and penia being a lack of. So destruction of megakaryocytes is a good way to produce thrombocytopenia. This happens in the course of certain diseases, let's say like in leukemia, which is basically a bone marrow cancer. The cancerous cells can blot out the normal megakaryocytes, and the patient can end up with a severe thrombocytopenia. Very importantly, and you'll learn this very quickly, is that many forms of chemotherapy used against cancers are limited in their applicability because they destroy lots of components of the bone marrow. They can destroy all the components of the bone marrow, but they can really knock the platelets way, way down. So things that destroy the marrow can produce thrombocytopenia, but there are also conditions where the marrow is producing platelets like mad, and they're getting consumed peripherally. And we now recognize forms of really immunologically mediated thrombocytopenic conditions. And you'll hear the moniker of ITP, immune thrombocytopenic purpura. So peripheral destruction of platelets is a very important sort of thing. Now, a third category, we talked about things that happen to vessels, something that happened to platelets. A third category of things is a deficiency of clotting factors. And you know, you look at the various components here, I won't bother naming them, but the various components, and these are proteins that are obviously under genetic control. Many of them are produced in the liver, but genetic mutations can lead to problems with the coagulation cascade. And I think you are all familiar, superficially at least, with one of them. It's a mutation in factor VIII. And what does a deficiency of factor VIII lead to? Yeah, you got a hemophilia. That's just one example, and there are others. Then I mentioned that the liver is the organ that synthesizes many of these clotting factors. So it's a possibility with severe liver disease, very diffuse liver disease, and very severe liver disease, that you get a failure of synthesis of one or more of these factors, and that will lead to hemorrhage. And then, just like with the platelets, there is a possibility that the clotting factors can be produced all right, but they can be consumed too rapidly, producing what we sometimes call a consumptive coagulopathy. In other words, if you use up the factors too rapidly, there's going to be bleeding. And you see this sort of thing in a condition, you've probably heard about it, we talk about disseminated intravascular coagulation, DIC. It's a situation you'll encounter most often in septic patients, but with disseminated intravascular coagulation, little tiny clots form by the millions throughout the circulatory system, and it can be that enough of one or more of these factors is consumed that the patient then begins, sort of paradoxically, to bleed because there's been too much consumption of the coagulation factors. That's really enough of that. I think you're impressed by this time if you have a patient who comes in with petechiae, ecchymoses, purpura, you've got an interesting diagnostic problem because there are a whole lot of possibilities that can lead to that sort of thing. Having said that, I want to turn to the possible effects of hemorrhage. What does it mean to hemorrhage? Well, we'll start with local effects. And I'll start with the good news. The simplest is you have an ecchymosis or a hematoma of a varying size. Let's talk about the good old-fashioned black and blue mark. At least it's black and blue as seen through paler skin, but it's a bruise, basically. How is a bruise or a big ecchymosis taken care of? And I'll take you through the stages. You've all had bruises on your skin, and you know it goes from a sort of purplish-looking thing to a ripe banana phase, and then gradually fades out. Here is a pretty good ecchymosis in a thigh. And it's fresh. And here, whoops, it's fresh. The blood is not purple. It looks purple as viewed through the skin, but basically that's blood dissecting through the tissues there. And if you go back, as we did with the camera, a few days later, it's already partly resolved. Part of it's been chomped up and carried away. You can still see the purple, but you're beginning to see sort of a brownish blush there around that. And then some days later, it's really getting quite brown in much of it. There's still a little residue of where there was more blood here. And you can imagine that this would fade away through the brown and yellow and then live happily ever after. Now, I will show you what's going on microscopically so you can appreciate it the next time you get bruised. The first thing that happens early on is that macrophages come out. When blood is out of the cardiovascular system, it breaks down. It doesn't last like it does when it's circulating, so it breaks down, and macrophages come in to scarf up all of the red cell junk. And here, this is you can see these are sheets of red cells packed in here. Here, it's beginning to be chomped up, and what you've got is macrophages. There's a mac, there's a mac, there's a mac, there's one, and so forth. And what they are doing is chomping up these bits of red cells, and they're going to begin to process, this one you can see has got red cell fragments in it. It's going to begin to process those fragments, and you know one of the results is going to be hemosiderin. Here, I like this shot because here's the nucleus of a macrophage, and you can see the cytoplasm has got a bunch of sort of granular hemoglobin in it. There's probably another one there. And these cells have already digested what they've eaten, and you're seeing, what's the pigment called? Hemosiderin. Sure, they contain hemosiderin. And that's the pigment that we all know and love. And when you see that in the macrophages, it means generally that red cells have escaped the cardiovascular system and they're being broken down. There is another pigment there. I won't annoy you with it, just to show you a pretty picture. It's a pigment called hematoidin. And you don't read about this much in the textbooks anymore. People have forgotten about this because it's not important. This is the non-iron containing moiety as the hemoglobin breaks down. In other words, the macrophage is split into an iron-containing moiety, which is stored as hemosiderin, and this other, which is hematoidin, which doesn't hang around very long. This is probably essentially bilirubin. and it's carted off, but it's got a yellower color than the hemosiderin. Don't worry about this. I'm just showing you for cultural enrichment and so you can appreciate your bruises. And here's a low power view. This was a hemorrhage, I think, in the brain. But you see a lot of, under low power, a lot of nice brown hemosiderin-containing macrophages, and this yellow stuff up here is the hematoidin. This is the hemosiderin. If you did an iron stain on this, you'd see this. And all of this is the old Prussian blue reaction, ferric ferrocyanide. All of this is hemosiderin, but there is hematoidin, which people tend to ignore, but now you know it's there. So those are both blood breakdown pigments that gradually disappear. The macrophages wander off. The iron is recycled. The body can recycle this iron and use it for nice new red cells, and that's the way your bruises are taken care of. A hematoma, if it's large enough, sometimes doesn't resolve completely because the fibroblasts begin to come in and organize some of the debris before it can disseminate and get carted out of there. So you may sometimes end up with a scar associated with a hematoma. So that's a good outline of how blood is broken down, and the fact that many times hemorrhage is trivial. But sometimes a relatively small amount of blood can produce death. And I want to make that point that we're not talking about bleeding to death. We're talking about a little bit of hemorrhage in the wrong place at the wrong time. And there's an example. This was somebody, which I remember, this is 30, 40 years ago, an auto accident where somebody was knocked unconscious, and a well-meaning passerby propped him up against a tree or something, and he had a lot of facial injuries, was unconscious, and snuffled in a lot of blood. Well, not a lot, but there you have it. It's probably less than a cup full of blood, and it's in the trachea and both main stem bronchi, and you know what happened to that individual. Here's an individual who died because of about a tablespoon of blood. This fellow stepped off a plane, Detroit Metro, and became suddenly unconscious and died very, very quickly. And what we found, this is a bit unusual, this is about a tablespoon of blood right in the pons. Some vessels gave way within the brain substance and effectively guillotined him. So he died as a result of hemorrhage, but not as a result of blood loss. This was just blood in the wrong place. I can show you lots in brain. Here was obviously a lethal thing. This was actually an infected blood vessel, what we call, it's a misnomer, a mycotic aneurysm, but an infection in the blood vessel wall, so it went pow, and probably less than a cup full of blood exploding out in the center of the brain there is lethal. Didn't bleed to death, but bled to death in his brain. Here is a classical hemorrhage of a hypertensive individual. The blood pressure does bad things to some of the small blood vessels, particularly in the area of the basal ganglia, and you get that explosive kind of intracerebral hemorrhage. I know the history of this. I couldn't look at that and say, oh, that's a hypertensive. That's an intracerebral hemorrhage. Here's one where a patient basically this was a leukemic patient who was very, very thrombocytopenic, and a little bit of motion in there probably finished that off. So you can get very serious hemorrhage with thrombocytopenia, but when we talked about the petechiae, because of the vascular, the separation of endothelial cells, that's a very minor sort of thing, but it can be quite major. Here's an interesting one. You're going to see this. Yeah.
Why is it cow scarred? Did you say?
Why what?
Why is it cow scarred? Is it some kind of hemorrhaging cow scarred?
I'm sorry, I'm not getting.
Scarred? Why is it?
Oh, scarring?
Yeah.
Oh, here's an example. You're a great straight man. Thank you. This is an interesting thing. This looks like kind of like a pancake in there. And it's, let me explain where it is. You're looking at the top of the brain, and the dura, the tough membrane on top of the brain has been peeled back. And in the subdural location, below, between the dura and the brain, we have this thing. And what this was it started out as a hemorrhage between the dura and the brain. And these are almost always post-traumatic. Something hits the head or the head hits something, and little bridging veins between the dura and the brain get sheared, and blood begins to accumulate. And it can accumulate to a fair amount slowly. This is, over a period of time. And to the point where it doesn't resolve. And what you're looking at here, the brown is the color of the hemosiderin, of what's going on inside. It's a big mass of spongy, broken down blood and hemosiderin. And there's been an organization at the periphery forming an envelope around this. And this could, in a different tissue, it would just blend with the surroundings. But here, basically, this hematoma has been enveloped by proliferating granulation tissue and scar. And it would have eventually proceeded, to fill in and just be a big lump of scar. But the thing was expanding somewhat still, and it pressed on the brain. And that was it. It's just a question of space occupation. But this is a classic subdural hematoma in a phase where it's organizing and beginning to scar already. So you can get that sort of thing in the extreme. All right, those are situations then where they're strictly local effects. A cupful of blood, maybe a tablespoon or two of blood in the wrong place, and you can produce death. Beyond these local effects that go from trivial to lethal, there are systemic effects of hemorrhage. And these systemic effects are related to the volume of blood that is lost. In other words, it's obvious that if you lose enough of your circulating volume, you die. And it depends how much you lose, what percentage, what fraction, and how quickly it's lost. But you die. And we call that exsanguination when somebody dies. And the point I would make is that you can exsanguinate without dropping a drop of blood externally. In other words, with the wrong kind of trauma, you can bleed into a body cavity like the pleural cavity or the peritoneal cavity, or actually into the soft tissues like in the retroperitoneum. You can drop enough of your blood volume to die without ever the thing showing. And you'll learn in emergency department practice, and someone comes in after a traumatic injury, there may not be a mark on the surface, and the patient's in deep shock and no blood pressure. And one of the things you can do is get a needle into various cavities and see what's going on. And it's possible to exsanguinate that way very quietly. I seem to have skipped a slide here. Something's wrong with my advance, but so that's a possibility. I was going to try to show you a picture of a cracked liver, which I had. I think it's in your notes.
Go ahead a couple slides.
Did I miss it? No. Yeah, there we go. I'm sorry. I see what I was looking at the clock and rushing, and I meant to show you another situation where a little bit of blood can cause death without totally exsanguinating the patient, and that is if blood accumulates rapidly in the pericardial sac. You've dissected the heart now. You know that the pericardium is a tough fibrous sac around the heart. If the heart ruptures, which is usually the result of a myocardial infarct, if the heart ruptures, or if the intrapericardial portion of the aorta ruptures, blood will accumulate in the pericardium. And here you see a pericardium that looks very, very tense. And open it up, and there was this mass of blood around the heart. Not too much, probably about 300 or 400 cc's, as I remember. But that's enough that because the pericardium won't give in that situation, you get the blood accumulating around the heart, and it prevents diastolic filling of the heart, and the patient dies of what we call cardiac tamponade. And that's by a reasonably small amount of hemorrhage. All right, this is where I'm sorry I got lost here. This is a liver that is lacerated. You can see the lacerations in the capsule. What the picture doesn't show that the patient had a huge hemoperitoneum and died as a result of that. So that's an example of the internal hemorrhage. Now, in the remaining few minutes, I would point out some other possible effects, and one of them is that short of death, if the blood loss is sufficient, I don't mean a trivial amount, but I mean if you lose a fair fraction of your blood volume and don't die, it could produce a condition we call shock. And you've all heard the word shock. And I would implore you to read the section in the book on shock. It's a couple of pages. Don't get lost in the mediation of it, but just read about the patterns of shock. Now, shock, in very general terms, is a condition that involves a deficiency of blood flow in the periphery. And it's really a disproportion between the capacity of the circulatory system and the volume of circulating fluid. And if there's a loss of a disproportion between how much is circulating and what the volume is, in other words, too little circulating for the volume or too much volume for what's circulating, the pressure is going to drop. And what happens then is perfusion of all tissues begins to go down, 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 down. And if it's severe enough, the tissues begin to suffer from the hypoxia, and terrible things can happen. Now, shock occurs in a variety of situations, and I've just come into it by talking about hemorrhagic shock. In other words, if you lose enough of a fraction of your circulating blood, you go into shock, and we call that hemorrhagic shock. And it's a type of what more generally is called hypovolemic shock, meaning a low volume shock. And it's important to remember this because you can get hypovolemia by losing fluid from the circulating plasma. This happens in severe burns. Patient burned over 80% of the body surface, you're going to have a tremendous exudation of fluid into that area, and the patient can become hypovolemic very, very rapidly and drop into shock. So hypovolemic shock is some loss of circulating volume from hemorrhage or from other conditions. Another situation is when the blood vessels are all right, the circulating volume is all right, and the heart is clobbered and can't pump enough to push enough to perfuse the tissues. That's called cardiogenic shock. Then there's a situation where the heart's all right, the circulating volume's all right, but suddenly there's an inappropriate increase in the volume of the peripheral circulation. Everything relaxes and there's vasodilatation, and pretty soon you got too much pipe system for the volume. This happens in neurogenic shock when there's some neurogenic impulse, frequently trauma. Happens in anaphylactic shock, that's an immunologic cause. And finally, there's a very important form of shock which you should read about carefully because you'll encounter it, and that's called septic shock. And this is associated with overwhelming infection. And the pathogenesis is quite complex. You can, let's say, skim the book about it, but remember that what's caused here in septic shock is widespread peripheral vasodilatation. In other words, all over the body, the vessels are relaxing and opening, and at the same time, there is myocardial depression. The contractility of the heart is interfered with, and this all happens. I'm really simplifying it, but it all happens because of a massive release of cytokines. The book describes this very well. What happens to macrophages that are activated? There's sort of a storm of cytokines. The heart is depressed. The vessels open up, and actually endothelium is also in this situation diffusely injured, and this is when you get when you can get DIC. And that's that in a thimbleful is septic shock. So any form of shock involves some combination of loss of circulating volume, change in the capacity of the cardiovascular system, that is widespread vasodilatation, or ineffective cardiac pumping. And I think you're familiar with the fact that patients who are in shock will be hypotensive, their heart rate will go up, they will have a tachycardia, and the important thing is that they all end up, if the shock isn't corrected, end up with poor tissue perfusion. The tissues begin to suffer, and you end up, and this is typical in ICUs all the time, with multiple organ failure and death. Well, finally, as the bell is about to go off, one other point about blood loss that you've heard before, and I want to drill it into you again because it's important, and that is if blood loss is sublethal, I mean, it doesn't produce shock, but if it's either continuous or repeated, what can happen, well, it's as follows. I'll give you a happier example. You give a unit of blood. You know, you're a blood donor. Give a unit of blood. What happens is your blood volume is down by half a liter. Fluid comes back into the cardiovascular system very quickly to make that up, so you're a little bit anemic. In other words, your blood has been diluted by that fluid that comes back in. That triggers the bone marrow to increase and make more red cells, and you're happily off, and some months later you could give another unit of blood. But if we took a unit of blood off you every day, day after day, you know what would happen. Sooner or later, you're going to outrun the ability of the marrow to replete that, and outrun the iron stores of the body, and then a severe anemia is going to set in. And the point I want to make, and I'll actually show you a picture that you've seen before, is this is just one example. This is cecal carcinoma. And we made the point, I think in one of the MDCs earlier this year, that patients will come in complaining of ease of fatigue. They're droopy, they're pale, they're listless, and so forth. You discover they've got a profound anemia, and the reason may be a lesion like that has been oozing, dripping blood day after day after day after day, and sooner or later it will deplete the iron stores of the body, and you end up with an anemia of chronic blood loss. So that's something you've got to keep in mind. It may save somebody's hide someday. Okay, that's it. Thank you.